You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the Pre-Hospital Care podcast with myself, Owen Walker. In this session, I'm going to be looking at bleeding and coagulation in trauma with Ross Davenport. What I wanted to do in the podcast is just look at the utility and principles of coagulopathy and some of the novel approaches to coagulopathy within pre-hospital care. So we're going to examine the utility of fibrinogen concentrate, some of the distinct features of fibrinogen concentrate, and also cryoprecipitate. Now we'll look at some of the longevity of use compared to other blood products, how you constitute fibrinogen concentrate, and indeed plenty of other areas to examine as well. So to do this, I have Ross Davenport with me. Ross is a consultant trauma and vascular surgeon at Royal London Hospital in the UK. He's also a senior lecturer in trauma sciences and has previously worked in pre-hospital care for both London and Essex and Herts Air Ambulance. His research has focused on trauma-induced coagulopathy, acute response to injury, and the treatment of major trauma haemorrhage. So his work in traumatic coagulopathy and massive transfusion, inflammation, and organ dysfunction has had international renown. Welcome, Ross, to the podcast.
Thanks, Owen. Great to see you again.
Great to have you with us. Ross, I just wondered if we could just start by just examining and getting you to speak to the rates of coagulation within non-compressible hemorrhage and how we've seen sort of an improvement over the past few years.
Yeah, sure. I think if we go back to those first papers that came out from the work at London's Air Ambulance and then a couple of other big studies in America and the German trauma registry, most people still quoted at that time an ATC rate, so an acute traumatic coagulopathy rate of about 25%. And associated with that was a 4 times greater mortality. And what's interesting is we've seen an appreciation of coagulation in trauma. You know, it's much more refined now, but also our treatment has changed hugely over that time, obviously. Is that for an all-comer rate, probably coagulation in trauma patients now sits around sort of 10%. But what's interesting is that the mortality now associated with coagulation abnormalities in that smaller group of patients is actually much higher. So you're probably now about 6 times more likely to die if you have a coagulation abnormality on arrival. And that's probably borne out in a few different ways, because if you actually have a coagulation abnormality at the scene, and you are giving a balanced transfusion with blood and blood components now, you can mitigate that coagulation, and some patients will actually correct that coagulation before they get to hospital. But in those that are having the breakthrough coagulation despite giving that blood product resuscitation, that's where we're now seeing that really high mortality and where lots of research is actually being focused. The other thing we've learned, I think, is that calling a trauma patient just a trauma patient is probably not that helpful, because the coagulation abnormalities we see in someone who has penetrating injury or blunt injury, the time that you see the patient and how much blood loss has occurred actually produce very different phenotypes of coagulation abnormalities. So whilst we've made a lot of inroads in trying to understand it, and we certainly have improved outcomes globally, there's still a lot to do in actually trying to refine that very hard to treat group of patients.
So just looking at the rates of hypothermia within pre-hospital care and sort of the educational push and indeed the data push, just looking at the data, are we starting to see coagulopathic patients or presentations reduce because we're starting to get a handle on hypothermia, or what are we seeing in practice?
Yeah, I mean, I think people used to talk specifically about this sort of lethal triad, of which hypothermia was clearly an important component. But actually, when you look at the data, that hypothermia, to the extent where it actually starts to interfere with coagulation, in most settings is actually quite rare. There's no doubt that the education around keeping patients warm has mitigated some of that effect, but in reality you've got to get down to sort of 32 degrees before you start having some profound changes in coagulation. What's probably more important, actually, when we look back at that lethal triad is the other components of crystalloid resuscitation and its effect in causing a dilutional coagulopathy. That's very much gone away now, because crystalloid is hardly given, and if it is, it's given in small boluses. With many services now moved towards balanced resuscitation with either fresh frozen plasma or a lyophilized version, along with red blood cells, which is interesting because whilst that can correct, or rather hold people's coagulation at a certain rate, it doesn't often correct because it isn't giving a concentrated replacement of some of those blood coagulation factors, because it is a physiological product. And so there's an issue really of in patients who are having a very profound bleeding episode or are developing an extensive coagulation abnormality before they arrive in hospital, is that the products that we have mostly used are actually not sufficient, because they're just giving what you already have in your blood. And what you need to do if somebody has a deficit is actually give them a supranormal dose. And what we do know is that one of those clotting factors that's so important is fibrinogen. And there's a lot of work now that has supported the basic understandings of fibrinogen. I mean, fibrinogen is a clotting factor, just like the other clotting factors in your blood, but it is the building block of all blood clots. It's clotting factor number one. You simply cannot make a blood clot if you don't have sufficient levels of fibrinogen. And we know that fibrinogen levels fall for a number of reasons during bleeding. Just the process itself of trauma-induced coagulation will change how fibrinogen functions in terms of how much is produced and how quickly it breaks down. And what we have very clear evidence from, both in large civilian studies and also military data, is that if you have a low fibrinogen, you have a very high mortality. And it's a linear relationship. The lower your fibrinogen goes, the much more likely it is that you're going to succumb from your bleeding episode.
So Ross, could you speak to sort of the discovery of fibrinogen concentrate? So how does it work? Like you said, it's the building block and almost a mesh to the coagulation. But could you speak to its origins and indeed how it works?
Yeah, I mean, the understanding of fibrinogen and all of the clotting factors, lots of the work was done in the early 1960s, and understanding that the reaction between all these different clotting factors is important to actually ultimately generate thrombin, and then thrombin's role is to cleave your body's fibrinogen to turn a soluble clotting factor into an insoluble clotting factor. So it's polymerized, and then this will then form a mesh, which then traps the platelets and the red blood cells, and effectively then is a sticking plaster on the side of the vessel wall. And fibrinogen replacement as a concept has been around. It started actually around the work looking at treatment of haemophilia, and cryoprecipitate was actually the first product that was available to do that, which is a derivative from fresh frozen plasma, and it just actually is a small amount of clotting factors that appear in the blood, of which fibrinogen is the significant component of fibrinogen. But within cryoprecipitate, there are also other important factors such as von Willebrand factor and fibronectin. Now, fibrinogen concentrate is the next step on from that, because it is just a single protein. It is made from a pooled plasma, so pooled human plasma, and it is a concentrated version. So each vial usually contains between 1 and 2 grams of fibrinogen. It's a standardized product, so we know exactly it's the same amount of fibrinogen in each product made by the respective manufacturers. And it is a heat-treated and virally inactivated product. So cryoprecipitate in many countries is actually being phased out because of the concerns around pathogen transmission, and because of the variation in the product. Again, it's a blood product. Depending on what the donor is, will then determine what's actually sitting within the blood component bag that you get from the laboratory. So fibrinogen concentrate, particularly in Europe, has been used for a large amount of time because it's felt to be a much more consistent product. In the UK and in most of America, we still actually favouring cryoprecipitate. There's some reasons for that. Cost is also an important factor because fibrinogen concentrate is certainly much more expensive than fibrinogen concentrate.
Could we maybe look at cryoprecipitate for a minute, just how it differentiates from fibrinogen concentrate, and also just its comparative efficacy to fibrinogen?
Yeah. So one of the problems we have is that cryoprecipitate is a blood product, and so it is stored in a transfusion laboratory. It is frozen, and therefore, to get access to it, you have to alert the transfusion lab. They thaw the product that's then transported from the transfusion lab to the patient's side. And so there are inherent delays in getting this product. It, by definition, because it is a frozen product, it therefore makes it very tricky to move this type of product into the pre-hospital phase of care, because once it's thawed, it can only be used, or it has to be used within 4 hours. And even within the hospital setting, it is problematic because most studies suggest that upwards of 60 minutes it will take to actually call for the product and then get it into the patient. And we know, from a number of studies now that the median time to death for these types of patients from the point of injury, it sits around sort of 1.5 to 2 hours. So there's an inherent, disconnect between what is known to be an important product and then actually getting it into the patient in a timely fashion. In terms of a direct comparison with fibrinogen, concentrate that is, there is some important differences. One, fibrinogen concentrate is just fibrinogen. There are no other clotting factors within it, which in the context of a bleeding trauma patient, it's unknown how important those things might be. There was one study that was published using some of the data from the Feisty study, which was a head-to-head comparison between fibrinogen concentrate and cryoprecipitate conducted in Australia, is that the drug itself, fibrinogen concentrate versus cryoprecipitate, if we call it a drug, is it does produce different types of clots, and that might have something to do with those other clotting factors that are present. It certainly seems to suggest that a clot made with cryoprecipitate is stronger and actually more resistant to fibrinolysis, so the process by which clots are being broken down. A recent systematic review, which has tried to compare the efficacy of cryoprecipitate with fibrinogen concentrate, actually found that there's very little high quality data rather, to draw any meaningful conclusions. And certainly in the 4 studies that were used in that systematic review, they found no difference in its ability to correct fibrinogen deficit, the transfusion requirements, the sort of safety profile with regard to thromboembolic events or bleeding itself.
So just looking at fibrinogen concentrate compared to drugs that are maybe commonly used within prehospital care for bleeding, such as TXA, and just looking at sort of the effects on mortality, as far as my limited knowledge is aware, there's sort of diametric differences in the mechanism of action between fibrinogen and TXA. But could you speak to if there is any comparative data?
Yeah, I mean, I think you're right. They do work in completely different ways, but they are actually, if you like, the front and the back end of a clot, if you like, because the fibrinogen or the cryoprecipitate, the replacement of fibrinogen, is very much there to, replace what's lost to enable a clot to form, and that tranexamic acid acts to stabilize the clot and to stop the clot from being prematurely broken down. And we know in trauma that there is a massive activation of the fibrinolytic system, so the clot breakdown system, of which if you do not give tranexamic acid, these clots get broken down very quickly. And the evidence for tranexamic acid use is so overwhelming now that it is widely used empirically across a number of countries. And recently, on top of the CRASH 2 data, which is now sort of 10 years old, we've got the PATCH trial, which was published very recently from Australia, and also the STAMP trial from the US, showing that in whatever pre-hospital care system you have, is that tranexamic acid use, when given early, is associated with a mortality benefit. Now, if we come back to fibrinogen concentrate, the problem is, in respect to high-level evidence of randomized controlled trials looking at mortality, there simply is not the data there. It is used widely, particularly across the European continent, and has been for a number of years, as I've said, because they've phased out cryoprecipitate. But the cohort studies and the retrospective data does suggest that there is an improved outcome. But the important caveat here is that most of these studies, and certainly the algorithms that are published, are actually using fibrinogen concentrate to correct a known deficit in fibrinogen. So what I mean by that is that there is laboratory evidence that the fibrinogen, the Klaus fibrinogen from the blood test is low, or using a viscoelastic test such as Rotem or TEG, the fibrinogen component is low. So this is not blind empiric use, this is targeted treatment for a known fibrinogen deficit. And putting those two things together, there's a very nice retrospective study from the military, actually the MATTERS study, that showed comparing cryoprecipitate with or without tranexamic acid, is that the best survival profile was in those military casualties that had both cryoprecipitate and tranexamic acid, which sort of stands to reason. You have to give enough fibrinogen to make the clot, but then once you have made the clot, you need to actually stabilize the clot, and that's what tranexamic acid will do.
So just looking at fibrinogen concentrate from an empirical evidence perspective, there's been a lot of recent commentary about the results from it was the CRYOSTAT-2 trial, and indeed whether there was utility to giving fibrinogen concentrate to the trauma patient. Could you maybe speak to the recent empirical research and indeed what the findings show?
Yeah, I'm glad you mentioned CRYOSTAT-2, because it's it's one of the studies that I worked along with a number of other people on, and it is very clearly shown for the first time, I think, that we are moving into a different phase of treatment for massively bleeding patients. Lots of the data and the thought has been about an empiric approach where we basically throw the kitchen sink at the patient. So we give, a balanced resuscitation, red cells, some sort of plasma product. And then once you've bled to a certain amount, we'll chuck in some fibrinogen, which in the UK and the US is typically cryoprecipitate. And the CRYOSTAT-2 trial absolutely showed that there was no benefit to the empiric upfront use of high dose fibrinogen replacement. So in CRYOSTAT-2, this was a randomized controlled trial of 1,600 patients across the US and the UK, all the major trauma centers in the UK and some in the US. And it was standard of care, which was massive hemorrhage protocol. So your standard, code red or whatever, your algorithms in your hospital, but it was empiric treatment. And then in the treatment arm for this trial, they had early additional cryoprecipitate, equating to about 6 grams of fibrinogen. And in the two arms, there was absolutely no difference in mortality. The slight concern is that not only was there a difference in mortality, but in some of the subgroup analysis, now we have to be careful about the subgroup analysis because it's not the trial, it was not powered to look for these, although these were predefined subgroups, is that there was a signal for harm in the patients who had penetrating trauma, and also a potential signal for harm in those patients who were getting fibrinogen replacement early. So we looked at different timelines at which they got the treatment of the cryoprecipitate, and there seemed to be worse outcomes for those that got cryoprecipitate within the first 60 minutes from arrival in hospital. Difficult to really know what those things mean, but because this was an empiric trial, there are some of those patients who undoubtedly did not have low fibrinogen. And we know from some of the work published a while ago now that fibrinogen is very pro-inflammatory. It may have some bad effects on your brain if you've got an injured brain. And if you give fibrinogen to patients who've got a normal level of fibrinogen, which might be those patients who are getting into hospital early, they haven't had long enough to develop a low fibrinogen. And generally speaking, that tends to be the penetrating trauma patients as well. They're not trapped. The scene times are generally shorter. So my, thoughts about what this, might be pointing to is that fibrinogen may be beneficial for you, but only if you have a low level of fibrinogen, and it has to be a confirmed low level of fibrinogen, because that CRYOSTAT-2 trial, just to really, hammer it home, there was no benefit to giving empiric treatment of high-dose fibrinogen. Now, the counter to that is that, there was a lot of biological rationale that replacement of fibrinogen is good for you. Correcting fibrinogen has shown that, you will have improved outcome in the retrospective data, as I've said before, in the military and the civilian settings. There were a number of small trials, again from Europe. There was actually a pre-hospital trial called the FinTIC trial that looked at pre-hospital replacement of fibrinogen concentrate, all showing that you can improve your fibrinogen level. There was a suggestion that you could correct your overall rates of trauma-induced coagulopathy, and also you could reduce some of your surrogate outcomes, such as multiple organ dysfunction. But these were small studies, they weren't powered for mortality, and effectively they were feasibility trials. And when you go back to, what the guidelines are telling us, the most recent European trauma haemorrhage guidelines, and when you look at all of the European utility of fibrinogen concentrate, it's all based on a defined fibrinogen deficit rather than blind treatment. So I think there's lots to do, still come out from the CRYOSTAT-2 trial and try to understand what the data means. But I think, we're moving away from a one-size-fits-all, as we are in lots of elements of medicine. And we're really talking about a precision approach to a bleeding patient. And that some of the things that we give to patients are not without, potential adverse effects. And it goes to the reason, doesn't it, is that, you and I mean, if we had a trauma, we would respond differently. And equally, the patients that are having a blunt injury versus a significant blunt trauma, perhaps with a head injury as well, it's unlikely that those patients are all going to respond in the same way to having hemorrhage. And therefore, they're unlikely to respond in the same way to having a treatment as well. So to really bring that together, I think where we are is that fibrinogen, when you have a defined fibrinogen deficit, is probably good for you. But blind treatment is something which, one, it hasn't shown benefit in the trial, but also perhaps is harmful to a certain group of patients.
And I think what you're speaking to us there is this nuanced care towards bleeding, but like you said, in innovating the clinician with more information, either in or pre-hospital, whereby you can look at their fibrinogen levels and understand, like you said, targeted treatment, depending on undifferentiated treatment, maybe with TXA, which is protecting that clot, and like I said, is proven to improve mortality and morbidity across time if given early. But then, as you were saying, looking at maybe more targeted treatments and looking at fibrinogen levels, especially in patients where there is maybe an extended seeing time or indeed transfer time to hospital. And it sounds like this sort of nuanced care is where it's heading. Could you maybe speak to how easy it is to reconstitute fibrinogen concentrate? TXA is easily given within the pre-hospital environment, but and you spoke to how difficult it is to reconstitute or indeed unfreeze cryoprecipitate to give it. Is it what's the process with fibrinogen concentrate? Is it easy to give? Is it quite difficult to give in the pre-hospital environment?
Yeah. I mean, it's generally quite easy. It's a powdered product, and that obviously has a lot of attraction for pre-hospital care or any sort of austere environment, because its shelf life is very long. It's temperature stable, and effectively you just put some water into the bottle. Some of the earlier products, and some, there are differences between the manufacturers. It can foam quite a lot, but generally speaking, you mix it up, you reconstitute it, and then you can give it over sort of 5 or 10 minutes, and it is given, as I said, the use of fibrinogen concentrate is huge across Europe, and also some military services are using it as well. It comes back though to actually being able to diagnose the patient that you want to give it to in the pre-hospital phase. And what's interesting, there are also now a number of diagnostic companies who are looking at points of care fibrinogen tests. I know 2 already have actually got a prototype, or one that's soon coming to market, because if you then had that at the roadside or at the scene of the incident, then you've got your go signal to giving this product And clearly, if you have a fibrinogen deficit, the sooner you get it into the patient in terms of replacing the fibrinogen, the better the clotting is going to be. So there definitely is a role for trying to push these things into the pre-hospital space, but it's about patient selection is the most important thing. The other thing that's coming down the pipeline is that there are people looking at lyophilized versions of cryoprecipitate, as well as freeze-dried products, which does also have the potential additional benefit, as I said at the beginning, that there are some slight differences between how cryoprecipitate and fibrinogen concentrate work because of the different clotting factors that are sitting within cryoprecipitate. So that's also going to be potentially exciting area to look at. And I know that there's a clinical trial that's going to be looking at that product in the US in the near future.
And that's fantastic, and like you say, it speaks to this very much nuanced care at point of care, with more information at the fingertips of the clinician, but like you said, are very much targeted to the right patient, with all other aspects of the basic and essential care in place as well. And that kind of answers my next question, which was around sort of where in the patient journey it would be given. And it would be intuitive if there is these point of care diagnostics, or indeed fibrinogen levels, that you would be able to target fibrinogen concentrate within pre-hospital care according to the levels or deficit of levels, if that was the case, which is really exciting, really, because like you said, it gives you a whole further card array of treatments according to patient need. And I think the longevity of that really is around. It doesn't almost matter whether it's in London or somewhere in British Columbia, 4, 5, 6 hours away from definitive care, because if the patient needs it there and then, they receive it there and then. But Ross, could you maybe speak to just some sort of salient take-home messages for listeners around where we are within the literature base, where we're headed at the moment, and where you see things moving to maybe in the next few years?
Yeah, I mean, I think what we've really, on the journey of coagulation in trauma is it's come on a lot in the last 20 years, but it hasn't come on that much, because whilst we understand that there's an endogenous process, it's not just about what we're doing wrong to the patient in terms of giving them the wrong type of fluid or letting them get cold, is that there is an endogenous process. We've largely removed those harmful elements of our iatrogenic coagulopathy, but we are still left with this endogenous process, of which fibrinogen deficit undoubtedly is a very important factor. And we have some products which are definitely suitable for correcting fibrinogen. The gap we have is in terms of how we actually treat that, diagnose that, so we can bring that treatment further forward. And I think the second bit to that is that fibrinogen is just, one of those factors that does fall very early on, but there are other factors that occur later on in the bleeding phase. And as we said, you might have very long scene times, and they might be developing other problems, of which the drugs we have or the treatments we have just aren't there currently. And so other types of concentrated therapy are probably more important. There's a lot of interest in whole blood, and I think that's an evolving field, because whole blood is good from the evidence that we have, but it is still only physiologic. It is not a concentrated version of the factors that we know are low, and therefore you're unlikely to be able to correct them back to the normal levels that you need. So it might just hold people rather than actually treat the underlying problem.
Ross, that's fantastic and really informative, actually. And I just want to thank you for the last half an hour, because it's great just to be able to review the current literature base, indeed the empirical evidence which has come forward from Cryostat-2, but also just get your perspectives on where things might be going. So thank you, Ross.
No worries. Good to talk.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.